So the cervical vertebrae, we'll start with the bony anatomy. Remember that we have our 7 cervical vertebrae. Vertebrae 3 through 7 are fairly typical. The first 2 cervical vertebrae are atypical, so we'll look at those as more specifics and individually. Some of the features of a typical cervical vertebra that you see. You remember that the transverse distance of the cervical vertebra tends to be greater than the EP distance. Cervical vertebrae will have uncinate processes, which makes them distinct from other vertebrae. These little protrusions that are laterally, and we'll talk about the relationship with the vertebral artery for anterior approaches and its relationship to the uncinate process. Cervical vertebrae will have transverse foramina through all 7 of them. However, usually the 7th cervical vertebra's transverse foramen is not filled by vertebral artery, but just venous structures. We'll have anterior and posterior tubercles forming this so-called transverse process, and then our transverse foramen. You'll note that superior articular facets are going to face superior and posteriorly, and they're lying more or less in a transverse plane. The inferior articular facets that we'll see on another picture are going to face anterior inferiorly. So the joints that are formed, we have our inner body joints. We also have our zygapophyseal or shortcut facet joints. This is a typical cervical vertebra, the superior articular facets. You can see nicely the uncinate processes here laterally. There's some debate on whether or not the uncinate processes, when they articulate above and below, if they form an actual joint or not. But again, we'll look at those in regard to the placement of the vertebral artery. Many of the cervical vertebrae will have a bifid spinous process, as you see here. That's typical except for C1 and C7. You'll notice that the vertebral canal tends to be large in the cervical region due to the cervical enlargement of the spinal cord, which is in this region going primarily to the brachial plexus. Here are the 2 odd birds of the cervical spine, C1 and C2, and it's imperative that the union between this odontoid process of C2 and C1 is maintained so that the structures posterior to it, in other words, the spinal cord, remain without any pressure pushed or applied to them. C1, this is the atlas from above and below. You'll see it has a large superior articular facet that usually has this bilobed nature. The inferior facet is a little more oval. The superior aspects will also show you the anterior arch with a little facet, and that's where there's an articulation with the dens, or the odontoid process. The dens also has an articular facet on its posterior border, which is just for the transverse ligament. We have anterior and posterior tubercles for muscle attachment. In the front, this is for the longus colli muscle, and in the back, this is for the rectus capitis posterior minor muscle. For the spine surgeon, when we're looking for the cortical relationships of C1 and screw placement, this is an important type picture as a take-home that you don't often see, but your screw placements come in this trajectory, and you're aiming for cortical bone here. Trabecular bone is here in the lateral masses, and obviously the 2 places to avoid getting into the vertebral canal or the vertebral artery. C2 has some peculiar anatomy. Here it's superior facets, and it's only when you take off the superior facet of C2, like I've done here, that you can actually see what the pedicle of C2 looks like, and it's just this little bridge of bone here, just medial to the vertebral artery that would lie here, and then there's our vertebral canal. If we looked at a view from the side, it gives you a perfect image of the pedicle of C2 here, and this was actually a specimen that we practiced putting in C2 pedicle screws, so finding this inferior articular facet, aiming just above it and driving up in this direction, right? Avoiding this area, which would be where the vertebral artery lives, this vertebral artery cave, and then the inside of the canal here more medially. Some more typical cervical vertebrae. This is the vertebra prominens, or C7, and you can see a common starting point that one would use for pedicle screw placement. You can also see that the angulation of the pedicle here at 7 in particular has a wide range between about 40 and 50 degrees off the midline. Some of the ligaments that hold these bones together, we have running up the front of the vertebral bodies, the anterior longitudinal ligament. So that runs from the sacrum all the way up to the skull base. It changes its name here. So at C1, C2, we call it the anterior atlantoaxial ligament. And here it's the anterior atlanto-occipital ligament. And obviously, just like the ALL, these both help limit your hyperextension of the cranial-cervical junction. Posteriorly, we see the posterior atlanto-occipital ligament, which is joining C1 to the base of the occiput. And just below that, we see the atlantoaxial ligament. And you'll remember that these are cranial extensions of the ligamentum flavum, so they have a little more elastic tissue in them. These are the complexity of ligaments that help hold C1 to C2 to the base of the skull. Just for review, we've flipped out the tectorial membrane, and remember the tectorial membrane is just the cranial extension of the posterior longitudinal ligament. And once you peel the tectorial membrane away, you'll see the cruciate ligament here, right, with its horizontal component being the transverse ligament, which is really the essence of craniocervical stability. We have some accessory atlantoaxial ligaments, and then alar ligaments off of the odontoid, and then a tiny little apical ligament that doesn't do very much as far as craniocervical stability. Here we see some nice capsular ligaments. They're holding the O1 joint and then the 1-2 joint here. Without the capsular ligaments, you can see the joints themselves. And those capsular ligaments, as I'll show you a little bit later on, are actually extremely, have a high tensile strength. So the transverse ligament, just to give you a comparison of importance as far as tensile strength, transverse ligaments at the top of the heap with about 400 newtons. Alar is about half of that. Tectorial membrane around 80 newtons. Some of the essential muscles that you see with the posterior cervical approach. So this is the upper part of the trapezius, right, attaching here along the nuchal ligament and the cervical spinous processes. Next layer, if we take the trapezius off, this is the splenius capitis on both sides, with the oblique appearance also having attachment into the nuchal ligament. You'll start to get a little hint of the muscle just deep to the splenius capitis, and that's the semispinalis capitis. So this is layer by layer as you're doing your neck dissection in the midline usually. Here's semispinalis capitis, which capitis implying it attaches just onto the skull base here. And then not so much for function, but for landmarks during surgery, the suboccipital muscles, these little small bands of muscle that connect C1, C2, and the occiput together. And we'll see in a few images from here the relationship of these to some important blood vessels in this area. So nerve relationship in the cervical region. This is a spinous process, so we're looking posteriorly. This is the superior articular facet. And this is the transverse foramen, which would be filled with the vertebral artery. And you'll see just behind that transverse foramen is our spinal nerve. This is the dorsal root ganglia. And as you move toward the lateral aspect of the transverse foramen, you see the large extension. This is the ventral ramus. And in the cervical region, most of those from C5 inferiorly are going to go out into the brachial plexus. We see a little dorsal ramus. Remember I said that that's going to innervate the facet joint, the skin of the back of the neck, and then the native back muscles. And here we see little connection, rami communicantes, that will connect to the sympathetic trunk that is running just here on the anterior aspect of the bodies of the cervical vertebrae. This is that suboccipital triangle. It's probably not essential to remember these muscle names, but you'll see that they do form a little triangle, suboccipital triangle. And within that triangle, you see the third part or the horizontal part of the vertebral artery. So that's a landmark. This is the TP of C1. If you were doing a posterior dissection, you would come in the midline right through the nuchal ligament. And that vertebral artery, as it comes up through the transverse foramina, it's most laterally located here at C1. So it's done something like this. It then comes across in the vertebral artery sulcus, and then it pierces a little membrane that we just mentioned called the posterior atlanto-occipital membrane. From there, it pierces the dura and it becomes intracranial. For the spine surgeon, it's important to remember that from this posterior tubercle C1 to you would get to the edge of the vertebral artery can be 2 centimeters or less. That's important when you remember that the left and right vertebral arteries together supply about 1/3 of the blood supply to your brain, so you don't want to injure those. Here's the course of the vertebral artery. So it would have arisen here from the subclavian, and that's its first portion. It's the first branch of the subclavian. It then enters as its second portion, usually C6, transverse foramen, runs up through C1, transverse foramen, comes out into the sulcus, and then pierces our PAO, posterior atlanto-occipital membrane, and then dura mater. Great view of the nuchal ligament. So nuchal ligament from the inion all the way down to C7, and from there down, we would just call that extension the supraspinous ligament. Looking anteriorly, you see the relationship of the vertebral artery to the spinal nerves, right? So it has an anterior relationship to the spinal nerves as they come out in this little sulcus that's built just especially for the spinal nerves in the cervical region. Here's our uncinate process. And all the cervical vertebrae from 3 down have an uncinate process. Usually T1 also has an uncinate process. Now, if we look at the distance from uncinate process to vertebral artery, which would have surgical value, one study found that from 3 to 6, it's about 1 centimeter, 0.3 plus or minus. And then from 2 to 3, it's a little farther at about 3 from the uncinate process laterally. If we go back posteriorly, some of the neurovascular relationships of the upper C-spine and the cranial cervical junction, just to orient you, so here's the C1, here's our third part of the vertebral artery. This is C1 spinal nerve, suboccipital nerve. Here's the greater occipital nerve. Everyone remembers greater occipital nerve that ascends, comes out about 3 centimeters lateral to the inion, and then spans out on the back of the occiput to provide cutaneous sensation here, traveling with the occipital artery, which is a branch of the external carotid. You also see the upper part of the trapezius. Here we see a little bit of the sternocleidomastoid. And this is our third occipital nerve that gives a little cutaneous supply. And then you can go down 4, 5, 6 as far as cutaneous branches of these cervical nerves. You can make out the suboccipital triangle. Remember, that's a good landmark because inside that triangle is where we find the vertebral artery, the suboccipital nerve, and the posterior atlanto-occipital membrane, as well as the posterior arch of C1. This is a little more schematic, but shows you the relationship of the nerves. So if we've taken off the lateral masses with a saw in this picture, you'll see where the dorsal root ganglia live in relationship to the bone. These branches are the dorsal branches coming off, and you can vaguely make out some of the ventral rami. Here's our vertebral artery coming up from C2, C1, and then crossing over and entering the dura. You also note that, remember, in the spine, cervical spine, we have 7 cervical vertebrae, but we have 8 spinal nerves. So you have to accommodate for that by letting the first cervical vertebra come out above C1, and then we have the second cervical root come out below C1, here just above the second cervical vertebra. Thoracic vertebrae. If we look at the bony architecture, the canal of the thoracic vertebra is going to be smaller than in other places. It's circular in nature. It's because the spinal cord is smaller there. It has shingled superior articular facets, just like the shingles on the roof as you go top down. The superior articular facet points posteriorly. The inferior articular facet is an anterior location, as you can see here and here. The facets are in the coronal plane. Just the examples of T1 through T12, you get the idea that we have a circular canal, a spinal cord that's smaller because the muscles that it's going to are primarily your intercostal muscles, some anterior abdominal wall muscles, but not limb musculature, as would your brachial and lumbosacral plexuses. You get the idea that T1 is more like a cervical vertebra, T12 is more like a lumbar vertebra, and you can see the transverse processes starting to move in just a little bit. The ribs obviously are the landmark that give the unique nature to the thoracic vertebrae, and you can see here the attachment of rib at two places on most vertebrae. So one articulation on the body and then one articulation at the transverse process. The zygapophyseal or the facet joints, very similar as far as capsules and the amount of movement. The difference being that in the thoracic region, they're going to be in the coronal plane and not the transverse plane as we saw in the cervical region. Here's one of the landmarks when you're identifying positions to get into the pedicle of the thoracic vertebrae. And you have to take into consideration the positioning of the articular facet. Again, a great resource is the aofoundation.org, where you can find step-by-step exactly what those landmarks are and how to go about putting screws. Some of the muscles that we see in the thoracic region, so you see the continuation of the trapezius, and a good landmark is the very inferior part of the trapezius, usually ends on T12. So if you're trying to palpate and decide what vertebra is what, and you don't have the luxury of fluoro, or you're confirming fluoro, you can use that point as an added piece of information. When we take off the trapezius on the right, you'll see the rhomboid muscles, right? So if you need like a far lateral approach to the spine and you need to drop the scapula down, you can resect through the rhomboid major minor. You'll see a little bit of the serratus posterior superior. If we remove the latissimus, which comes from about T5 medially all the way down to the lumbodorsal fascia over the ilium, just deep to that, we see the serratus posterior inferior. And then those two muscles deep to will be the erector spinae muscle. So our serratus muscles, and they're basically little muscular tendinous girdles that are holding these erector spinae in place. Remember I showed you earlier that the oblique muscles laterally will send out a posterior lamina to the spinous processes here, and then there's also an a middle lamina that's going to the TPs, but in front of the erector spinae. This is if we remove the erector spinae, then we see these transversospinalis muscle groups that run here, and they more or less run between the TPs and the spinous processes, and they run from a lateral to a medial position. The one that's most familiar to folks would be the multifidus, right? And the multifidus will run from a TP in general to a spinous process, and it usually skips 3 to 5 segments from origin to insertion. If this is not clinically something you want to do, but you take out the spine and you see just some of the related neurovascular structures to the thoracic spine. And we see the intercostal nerves as they are coming off, and their attachments anteriorly into the sympathetic trunk. Just in front of the body, in the thorax, you're going to have the azygos system, right, which is draining the posterior intercostal vessels, and then that will split usually into an accessory azygos system. You see the segmental branches that are coming off the thoracic, descending thoracic aorta. These are doing just what we saw done in the earlier slides this morning, They're going back into the vertebral canal. They're supplying the bone, the spinal cord, and then finally the muscles that are around the spine, and then the skin of the back. So again, relationship, here's the intervertebral foramen from an anterior lateral view. We see the spinal nerve. We see that being crossed anteriorly by a posterior intercostal artery. And you'll follow little posterior intercostal veins that travel back to the azygos system. And remember, the azygos system eventually drains into the superior vena cava and then the right atrium of the heart. Here we see the dorsal ramus, ventral ramus, and then little branches connecting rami communicantes to the sympathetic trunk. I showed you this picture earlier, but in the thoracic region, usually a couple of centimeters off the midline, we'll see the cutaneous segment of the intercostal nerves as they come out and supply medial and lateral branches. These will also have lateral cutaneous branches that come out through the thorax more laterally and run both front and back. So some of the ligaments of the lumbar region. We have the anterior longitudinal ligament. Remember I said this runs from the sacrum all the way up to the skull base and is a combination of superficial fibers that span usually 5 or so vertebrae, and then a deeper level that spans just one level. Tensile strength is about 600 newtons, so it's one of the stronger ligaments, if not the strongest, of the spine. There's not as much elasticity. The fibers are crisscrossing, so they interlace with one another to help support things. And additionally, the ALL often has lateral extension, so this picture may not be extremely accurate in that you may have ALL that comes here on the lateral surface as well. Again, damage to this would be in hyperextension injuries. Posterior longitudinal ligament in the lumbar region, you'll see here. Remember we saw that extending cranially and becoming the pectoral membrane at the cranial-cervical junction. The PLL has these little wings that come off laterally at each segment. And on this view, you'd also see parts of Batson's plexus, the vertebral venous plexus, that are piercing through each of those segments and traveling into the basivertebral foramina that are just deep here. So pedicles. And PLL injuries occur with hyperflexion maneuvers. This shows several ligaments. So this is the anterior part of the spine, so the ALL. This is our PLL, intervertebral foramen. We see our ligamentum flavum. And ligamentum flavum has a lot of elastic tissue in it. It's almost like a big rubber band. Tensile strength is about 240 newtons. It doesn't cross the midline usually, so there's usually a central gap. So for example, with a lumbar puncture, you may not feel ligamentum flavum if you're exactly in the midline. It's intersegmental, so it runs from lamina to lamina. Right? It does not skip segments. You also see ligament flavum, as all spine surgeons will know, contributes to the formation of the intervertebral foramen. We also see the supraspinous ligament. It runs here. And the interspinous ligament. So supraspinous ligament, remember, becomes the nuchal ligament in the cervical region. Interspinous ligament is not as defined there. The two of these ligaments together have a combined tensile force of about 120 newtons. So in some cases, it might make sense to try to reconstitute those surgically for stability at these regions. The tensile strength of the capsular ligaments that I mentioned earlier, some people have measured as up to 600 newtons. So that's as much as the anterior longitudinal ligament, which even though there's not as much interest in the literature for these ligaments, it seems like biomechanically they offer a substantial amount of stability factor to the vertebra and its joints. Some lesser known ligaments of the lumbar region include the intertransverse ligaments. We see here, filled in medially would be our intertransversarium muscles. You get a good view of the ligamentum flavum from inside out, and there's that midline gap that I mentioned to you before. All right, that's probably a a good essential review. So I'll take any questions that you might have.